I think survivorship care really lends itself to a shared care model between specialists and GPs. And I think that as time goes by, we will see this model of care being implemented more and more.
I think a lot more of our transition can be into primary care, into patients seeing their GP. And GPs are very well equipped to facilitate most of those things, particularly wellness, psychosocial being. In many ways, they're better equipped than we are to deal with that. And certainly the late effects of therapy, we are able to educate the GPs about and work together with GPs around how to handle that for individual patients.
General practice has changed in the last 20 years. We are the specialist generalists. We're not solo GPs. Many GPs are multiple GPs with nurses, allied health, psychologists. The fact that these services can be utilised by cancer patients for their optimal care. I believe the second thing that specialists should be aware of is that we are interested in chronic disease management. We are interested in shared care.
We have very good recall and reminder systems so that we can actually support that regular monitoring and recall of patients, so that patients during cancer survivorship don't get sort of lost to follow-up, which is always a concern of specialists. There's a danger that specialists provide lots of information, for example, about all the detailed cycles of chemotherapy a patient has had, and that's not so relevant. It's more about what the consequences of those treatments might be, so what are the possible side effects and how to manage some of those common side effects.
One way that we can provide that information to GPs is through a document called a Survivorship Care Plan. And this is a document that's generated by the specialist that includes all the details of the patient's diagnosis and treatment, which may not be known by the GP, and also what their current health issues are and their potential health issues are.
From a GP's point of view, you need to have a very clear route of access back. So single points of entry back into a hospital system, whether that's through a nurse coordinator in the hospital or a single point of contact. Often GPs find it quite challenging getting their patients back into the hospital system. So having clear routes back in is a really key part of a good model of shared care. The specialists need to develop greater sense of trust that GPs are willing to take this on and actually can take this on. But there are some really key parts to make this partnership work. And just to reiterate, one of those key aspects is communicating well with the general practitioner. Supporting the patient to develop a trust in their GP, so that the patient recognises that the GP has an important role in their ongoing care. Helping patients to understand that the specialist is there to support the GP if needed. The other one is clarity of roles, and both during treatment but particularly after treatment, being very clear who is responsible for which aspects of care. And this is especially important as we move into shared care models. So there's clarity of who's doing what, when the patient needs to go and see whom. And so I think specialists need to both appreciate that general practice is willing to take this on, can do it if it's well supported, and that is again a key aspect of helping patients to gain trust in these new models of shared care.
I was very reliant on my specialist until I made this connection with my GP, and then it was really her, my GP, actually discussing with me about all the treatment options, me realising that really she's the critical part, she's the cornerstone really in bringing everything together. So I definitely saw that my primary point of contact is my GP in terms of knowing my holistic self.
So much of what can be done better in this area is communication. And it's important at the end of treatment or even at different stages of the treatment that the information we provide to GPs is thorough and clear. And there are opportunities to reference it to other documents which mightn't be specific to that particular patient but can also be helpful. What I'm referring to here are the optimal care pathways that have been developed through the Health Department and the Cancer Council of Victoria, and they are often a very good guide for what to expect for a patient right through the cancer journey.
At the Children's, we've recently opened up our online electronic record, and GPs have access to that, as do patients. They can dial in and look at their health online and all of their records essentially, which is a huge bonus. And I think from the paediatric sector will make that conversation much easier. It'll also mean that the GP can, in their own time, actually read up on that patient rather than having to contact a specialist within hours. And I think that electronic record is kind of going to slowly move through other hospitals as well. I think there's also the ability to do telehealth, which we do for some patients. It's particularly done for rural and regional patients, and that's something that could be done easily with general practice. Particularly as you get towards the end of therapy, we could have our GPs dialing in on those discussions.
If we look at systems of care, it's got to be team-based. It's got to be in the community, transitioning hospitals, and specialists, allied health providers and GPs should be able to provide information seamlessly so that the patient care is optimised. And an example I give is a patient that I look after in my area. He had a diagnosis of CML on a background of multiple sclerosis. It was up to our practice, our nurses, to engage with the haematologists, the allied health providers, and yes, he had great treatment, he had oral chemotherapy, but there were some side effects, and it was decided by the specialist that the general practitioner should look after the side effects of treatment. And that's where good communication equaled good care.